Hey Ahmad, can you hear me?
I can hear you. Can hear. We can see you, Dr. Ahmed. We can
Mumtaz.
see Ahmed too.
Worried I was going to be late. Okay, should we start?
يلا رح نبدأ بسم الله.
Yalla.
السلام
Good
عليكم.
afternoon, everybody. Can you guys hear us?
Yes, we can.
Abdullah, can you hear us?
Yes, I can see the slide. Everything is working well إن شاء الله. والrecording شغال. Doing good. Okay. السلام عليكم جميعا، يعطيكم العافية. بسعدنا وبشرفنا هذا الحضور يعني والإقبال الكبير بعرب HRS وعرب American Society of Cardiology. حبينا نعمل educational EP dedicated conference to be focused on uh, EGMs و to be focused on the يعني most specialized part of EP. This is going to be mainly dedicated or curated for EP fellows who's going to help in their EP boards. But anyone who's interested in EP or trying to learn and see what EP is about is also welcome. We have a very rich and interesting case and discussion with Ahmed Al-Tibi. He just graduated his EP fellowship from Yale University, moderated by Dr. Amin Al-Ahmed, EP attending at St. David Medical Center. بس قبل في عنا about 45 participants now. I'm gonna poll everyone. I just want to see ايش ال level of participation just so we can uh, curate, we can يعني direct our level of discussion to the most common. تمام.
I think this is great. One third are EP attendings, one third are EP fellows, and one fourth are Gen fellows.
We have about 40 answers. I'm gonna end the poll and share results. عندنا mostly يعني between EP fellow, EP attending and cardiology fellow that is definitely EP inclined. I think يعني we have room for يعني some advanced EP discussion. The ones who answered others وحتى الكارديولوجي fellows, I would love to see which level of which year of fellowship you are. Feel free to send some comments. في عنا كثير medical students. Uh, Throughout the entire presentation, feel free to use يعني the comment section. Feel free to use the poll section if we have questions. We want this to be a live discussion. الشغلة المهمة إنه يعني this is a new presentation, this is a new conference that we're creating, there will be some growing pains. فبدنا الكل يعني يتحملنا. We really owe you everyone. يعني we really owe you for being here. We thank you so much, but we need more feedback. We need guidance and assistance. We need you to keep following with us. It would be really helpful if at the end of this we get some feedback from you on what we did well, what we could do better in the future conferences. Without further ado, Ahmed, go ahead.
Shukran, Abdullah. Thank you guys. Really great turnover. We have 53 people. طبعا I'm going to start by thanking Dr. Amin Al-Ahmed غني عن التعريف يعني for your time. I know you're traveling in Amman. Thank you so much. Really appreciate your expertise today.
A pleasure. I'm here to learn, so this is going to be fun.
Thank you. I'm going to also thank really 14 EP fellows who volunteered to lead this platform. We started EP Inside. This is our first seminar. This is going to be a monthly seminar. I don't want to repeat what Abdullah said, but I really want to thank 14 EP fellows who stepped up and volunteered to give a monthly seminar. It's all, inshallah, going to be a high-level EP education. I have no disclosures. I just completed my EP fellowship at Yale University. I'm transitioning to practice, hopefully next month. And the other thing I want to say, I know the audience, we have various level of expertise, but I try to tailor this talk to basically early learners, basically EP fellows in their first or second years. So the content might be a little bit heavy for general fellows, and it might be a little bit on the basic side for people who have been doing this for 20 years. فتحملونا شوي. So this is a case actually we did at Yale New Haven Hospital. This is a 22-year-old gentleman he's actually an athletic guy. He's a junior ice. He's an ice hockey team player. Young guy. He was undergoing pre-participation screening, and during the pre-participation screening, he has an abnormal EKG. Upon further inquiry, he was found to have 2 episodes of palpitations. One of them was associated with near syncope. Given the alarming finding on the EKG and the symptoms, an event monitor for 30 days was prescribed, and he was having runs of SVTs. They're not long-lasting, maybe 1 to 3 minutes, but he has like 17 episodes. Interestingly, he did not report symptoms with these episodes. We get an echocardiogram, and echocardiogram showed a structurally normal heart, normal LV function, and no valve issue or any structural abnormalities. So also, we're going to touch base on this, but part of the recommendations in the clinic, he was recommended to not be restricted from exercise, which is something we're going to touch base on. He is an ice hockey team player, contact sport, but he was not restricted from exercise. And he actually played in the entire season of hockey that year. And he did well. So he presented to our EP lab and underwent an EP study. Just to give you a little bit of more information, this is one of the rhythm strips we had from his Holter monitor. So as you can see, we have a narrow complex tachycardia here. Heart rate is almost 170 beats per minute, I would say. And anytime you see a narrow complex tachycardia, the first question you're going to ask yourself, this is like a long RP tachycardia or short RP. So you're going to try to discern where's the P wave. I kind of tried to squint with my new glasses. And honestly, I kind of struggled to find a clear P wave. I don't know if this tiny deflection at the end of that T wave can count as a P wave. Honestly, it's not clear cut. So I call it an undifferentiated SVT. I don't know if it's long RP or short RP. And with that, the differential is still broad for me. As you all know, for early learners, for first-year EP fellows, short RP tachycardia, you should start thinking about typical AV and RTs. If it's very short, then you also start thinking about AV-RT, and it's going to be less likely of a possibility to be an ATAC. On the opposite, if it's a long RP tachycardia, you start thinking about ATAC first, atypical AV and RT, and you cannot rule out AV-RT completely. So this is your broad differential. Also, you're going to try to look at the initiation and termination, and the event monitor did not show me an initiation or termination. I always love to see how did this started. Did it start with a PAC? Is the PAC morphology similar to the P wave in tag? Do I have like an AH jump or like PR prolongation surrogate for an AV NRT initiation? We don't have an initiation, so I cannot comment on this. Likewise, we don't have a rhythm strip showing the termination. When termination, you primarily try to focus on how did we terminate? Did we terminate with a V or with an A? If you terminate with an A, it kind of makes ATAC, people say like it excludes ATAC. The more proper way to say is makes ATAC extremely unlikely if you terminate with an A. So if you terminate with a V, I think your differential remains broad. So just based on this rhythm strip, I think our differential is still broad in terms of this SVT.
Ahmed, one comment. You described it beautifully. I think the thing you said at the end was very critical because understanding onset and offset is important with these. Because somebody who's young and athletic, this could be sinus tachycardia. You see that little thing at the end of the T wave, that could be a P, and this could just be the guy who's exercising. Particularly towards the end of the rhythm strip, it differentiates a little bit more in the smaller print. So having the onset and the offset is critical, but I agree with exactly what you said.
Sure, especially he's young, so he can have a very fast sinus rate. So next this was one of the rhythm strip. Actually, this was the predominant rhythm strip in his, like when he's at baseline. And just for the sake of time, you can see, guys, that patient is in sinus rhythm here, but we can see that we have a delta wave consistently in all the beats, and we have very short PR intervals. So we know this patient is pre-excited at baseline. We know he has an accessory pathway. The question is, this accessory pathway related to what we saw on the monitor, the tachycardia? We don't know yet, because essentially this could be an innocent bystander, or it could be the tachycardia could be actually be pathway related. So we need more data. The other rhythm strip that was interesting was this one, which I think it's his sinus stack. He was going at 138 beat per minute here. And the interesting observation here that the delta wave either was completely abolished, or maybe he's minimally pre-excited here. It's hard for me to tell. This is important because, like, when you start thinking about risk classification, you want to see is the delta wave, is he pre-excited all the time, or is it intermittent pre-excitation? And also you want to see how did you lose this pre-excitation? Was it like an abrupt loss, or was it like a gradual loss? Because I think when we do an exercise stress echo, we always say like to risk stratify as a low risk pathway, you want to see an abrupt sudden loss in pre-excitation. So I think this was an interesting strip here to just observe what happened to the delta wave when patient was in sinus stack.
But allow me to interrupt here. Can you go back to the previous slide? I just saw this. I know we went over the slides, but look at the bottom strip of this. There is what appears to be abrupt loss of pre-excitation just in the third beat that is under the yellow shadow on the bottom strip. The first beat is pre-excited. Second, yes, and I think the third beat, so just in the middle of it, under the blue shadow. Keep going, yeah, there. This is pre-excited, and I think the third one is lost. So I think this may be also acute loss of like abrupt loss of pre-excitation, but obviously you can't be sure of this.
I
It's
see.
better to see it on 12 lead.
I see.
I agree. It's harder to tell on one of these, but still, I think that's worth looking at. I think you have to look at everything with these, but very, very good pickup.
Okay. So next, this is his 12 lead EKG on a good day. That's his baseline EKG, and this is like reproducible. So again, we are in sinus rhythm here, and we see some pre-excitation. We see a delta wave, short PR interval. So we know that patient is in sinus rhythm and he's pre-excited. The question here that's gonna come to us as EP is, we know he has a pathway. Where is this pathway coming from? And we can do a poll on this if you guys would like. I'm going to give you 30 seconds before we give you the options. So do you guys think this is a left lateral accessory pathway? Is it septal anteroseptal accessory pathway, posterior septal accessory pathway, or right-sided, like right lateral accessory pathway?
Sorry, Ahmed, can you go back to the EKG, please?
Absolutely.
So remember, this is just something that gets you pretty close to the ballpark. Most of the time, you can detect exactly where these are with the ECG. Occasionally, you're close, but not exactly. In particular, on the right side, it can be a little bit more difficult. But I think here, let's see what the poll says.
Do you also care if patient is maximally pre-excited, or sometimes like you have just a subtle pre-excitation which messes up with the localization? So I can try to localize using maximal pre-excitation during the EP study.
Yeah, the more pre-excited, the better it gets, in particular for a left-sided pathway, because the left-sided pathway is a little further away. So sometimes those are not fully pre-excited, but you can get a hint that it's left-sided with a, R and V1, for example, or something like that. So um, to me, I would say this is a left posterior septal, but you can be fooled sometimes with these. I've had a couple that have fooled me. Yeah, so it looks like majority said left posterior septal.
Abdullah, you want to walk us through this? What do you think? What did you vote first?
Yes, so I agree. I think it's left posterior septal. I was impressed by when Dr. Ahmed said the majority of time you can very accurately localize it. I was gonna say out of either wisdom or apparent wisdom or ignorance that you always have to map and this cannot be 100% sensitive just so I can protect myself. But anyway, I'll just walk through what I thought, my thought process. If you want to walk by the Arruda criteria, the first thing to look at is the delta wave in lead one. And it's clearly positive here. So that takes us to step two. If this was negative in lead one, then it would have been a left lateral pathway activating away from lead one, exact opposite vector. So we go to step two, which is looking at lead two. Lead
Let's wait.
two,
For step
my
one,
initial.
Abdullah. For step one, Abdullah, do you also look at V1 RS ratio? Because I think that's the algorithm too. If you have a RS ratio more than one, it also goes with left lateral and V1. Sorry for interruption. Go.
This is a good point. So if RS ratio in V1 was more than one, then that's also left or left lateral. And my question here is, I see an R, but S is probably bigger than the R. R prime is bigger than both. So I don't know if that counts as a positive Aruda criteria, but I'm starting to feel just by looking at V1, which we will come back to, that this is left-sided. And then quickly touching on the second step of the Aruda criteria, lead 2 appears to be isoelectric. Initially, that initial force looks negative, but I think that's part of the QRS. There is clearly a flat line between the P wave and the beginning of the QRS complex. So I want to call this isoelectric, but I also want to keep in mind that we may end up mapping at least near the coronary sinus os MCV. But I will call this isoelectric and go to the third step. And V1 here is clearly a right bundle branch pattern with a very strong initial positive force. So I would probably, start making conclusions that this is a left-sided pathway. And based on the Aruda criteria, AVF will determine how posterior or anterior. And AVF here is also negative, so meaning your wavefront is departing in the same opposite to the AVF. So it's coming from low to high. So meaning it's posterior. So that's how I agree with everyone who said left posterior path.
One thing to mention, if it's left lateral, it's easy. You just go to the left lateral, you know it's going to be there. Left posterior septal can be funny because sometimes you have to be very, very septal to get these. And then you have to really be prepared to map the right. So you have to be open-minded about mapping both potentially in something like this. But if the left lateral, it's very straightforward. You just go to the left lateral. But the posterior septals, it's a small space. Sometimes just be ready to map both if you need to.
Great. Thanks, Abdullah. So Aruda algorithm is, I think, when I started fellowship, is one of the simple algorithms I use. I mean, it's not a Bible. It has its own limitations, but it's something to. I mean, with time, you will kind of start making sense of these algorithms, and you will basically, rather than memorizing them, you start understanding them. So step one is looking at lead one, and if it is basically negative or isoelectric, this goes with the left lateral pathway. And then you look at step two is lead two, and if it's negative, you should start thinking about the coronary sinus and mapping in the coronary sinus. As Abdullah said, AVF will tell you how anterior or posterior you are. If your AVF is more negative, this will put you more on the posterior side. So this is just, I'm not going to go over it, just for our reference. There's many other algorithms actually out there. There's smart WPW. I saw there's an easy WPW, but the concept is pretty much the same. Some people start by looking at V1. If it's positive, they localize to the mitral annulus, and if it's negative, it's more on the tricuspid side. The concept is the same. So why do we localize? So just want to highlight that we don't only localize to pinpoint where we wanna ablate and map. Localization should start in the clinic, because this is how you're gonna consent your patient about. This is how you're gonna number one, it's gonna affect how you're gonna consent your patient. Number two, it's gonna affect how you're gonna procedurally plan for this procedure. We know that left lateral accessory pathways are the most common, 60-65% of pathways, and these tend to be like an easy pathways, as Dr. Ahmed said. High success rate, typically stable catheter. You just have to be prepared to transept. You have to tell your staff that you will need a transeptal system, and you will be giving heparin for ACD more than 300. So from procedural planning, just you have to be prepared. Also, the second most common pathways are posteroceptal, and 25% of pathways are posteroceptal. For posteroceptal pathway, they don't have that very high risk of complete heart block like anteroceptal pathways, but they really can have a complex anatomy. Sometimes you have to go on the right side to get them, sometimes on the left side, because they can have also multiple insertions. Classic association for board exams for EP fellows is the CS diverticulus. So I think 10 to 15% of posteroceptal accessory pathway can be associated with CS diverticular. So many times, if you get stuck in the case, you'll see some operators shooting a venogram in the coronary sinus to rule out the presence of a CS diverticular. The third common, no, it's not common. The third pathway is anteroceptal pathways, and these are the dreaded pathways because that's where you have the highest risk of complete heart block, mid-septal and anteroceptal pathways. So if you are bringing a 20-year-old guy who is like an athlete to the lab to do an anteroceptal pathway, you better have discussed carefully what is the threshold to ablate, and carefully discuss the risk of complete heart block, possibility for a need for a pacemaker, and maybe you will have to consider also having cryoablation catheter ready. So all these are considerations are part of the pre-procedural planning. The risk of complete heart block is quoted around 5% in anteroceptal pathway. And finally, the right free wall pathways are like 10% of pathways. The one thing you need to know about these pathways are they can be really challenging to ablate because of the catheter stability, particularly with the movement of the tricuspid annulus. So localization is not just to know where to burn. It's also part of the pre-procedural planning. It's also part of the consent process for your patients.
One thing I would add to that, Ahmad, is a right anterior sometimes, or an anterior on the right. Just consider jugular access, or if you're failing or finding difficulty with groin access, go from the jugular, and sometimes you can hook it. So,
on the tricuspid annulus. Nice. So this is an example that we had at some point of a posterior pathway, and this is showing the CS body here, and this is an example of CS diverticulum. So this is associated in 10% of posterior accessory pathway. And typically the literature reports that typically you will get this pathway by burning at the base or at the neck of this diverticulum. So it's something to consider shooting a venogram in some of these stubborn pathways. I have two questions to Dr. Amin. Question number one is, you have an athletic like this guy, assuming he has no symptoms. So my question to you is, this guy walked into your clinic, pre-participation screening, he have a delta wave on his 12-lead EKG, he has no symptoms, you get a Holter monitor on him, did not show any TAC, and his echo is normal, so he just have a delta wave on his 12-lead EKG. How would you manage this patient, and what's your threshold to bring this patient to the EP lab? And the second question to follow up on this is about sport participation. If you only have pre-excitation with no clinical tachycardia, would you restrict this patient from sport, including contact sport?
Yeah, I would say if they're pre-excited with no symptoms, I don't think I would restrict them from contact sports at this stage. I might give them a Holter, do an echo, kind of understand that. As far as asymptomatic, if they're asymptomatic pre-excitation, I have a long discussion with them about theoretical risk in the future. And then the idea of how fast can this thing conduct can potentially be important. And also what plays into this is location of the pathway. Is it something, asymptomatic anterior septal on the right is different than, left lateral. So, but many times, we opt to do an EP study just to answer that question and ablate if necessary. But I have that discussion with the patient that they're truly asymptomatic. And I think the pendulum is swinging a little bit, that even the asymptomatics may deserve an EP study, but different people practice differently.
And how often do you exercise stress those people?
Yeah, so I do, but I don't know. I don't always
Trust
hold
the.
that as the gold standard. I think I want to look at several different things, or how pre-excited are they in clinic, and I dig deep for the symptoms. How much are they having, if any? I really try to dig at symptoms, um, give them a Holter monitor. If you exercise them, I think it's a little bit difficult because there's some adrenaline slicking the node up. So it's hard to necessarily make anything of it. But if it's an abrupt loss of pre-excitation, it's usually something helpful potentially, but it doesn't always correlate perfectly with somebody with a low ERP or high ERP, sorry.
Sure.
Uh, While we have this question, when do you shoot contrast to find a CS diverticulum? I think only in the cases where you're mapping in the CS os, one that has a negative in lead 2, and you're unable to get it, then shoot contrast is useful. I personally have never had to use contrast. I've had a couple of these, and usually you can find them by probing with the catheter without contrast, but sometimes it might be helpful.
Thank you. Abdullah, do we have any comments? Oh, someone asked already. We already answered this question. Okay. Thanks, Lee. I'm going to keep moving. So basically, we have a patient with symptomatic, with palpitation, symptomatic, pre-excited. So we brought him to the EP lab. And essentially, our access strategy was we had 3 access points on the left femoral vein and 2 access points on the right. So we have 3 6 French on the left side, 1 for HRA, HIS, and RV catheters. And on the right side, we have an 8 and 7 Frenches. The 7 French, we use it for the CS catheter, and the 8 for the basically the Agilis sheath, STSF, or whatever ablation catheter we use. So this is our setup for access. And this is basically our basically catheter positions in the heart. You can see we have HRA catheter here. We have our CS catheter, RV catheter, and HIS catheter in their corresponding positions. And very important when we're expecting a pathway to make sure that you have the CS catheter in proper position. You don't want it just to be hanging just the tip of it in the CS. It has to be properly positioned in the coronary sinus. Otherwise, your interpretation of your EGM will be all screwed up. Okay, so patient is in the EP lab. We started our EP study here, and just again, baseline interval. This is our baseline. So the green is our HRA catheter. His is in the turquoise color. The CS is in the yellow, and the purple is the RV catheter. And these are our surface EKG. So here we are trying to just getting some baseline intervals. I'm measuring our AH interval. Again, a lot of emphasis for first-year EP fellows. They're going to ask you, they're going to ask you how you're going to measure your AH. And the consensus is to measure it on your local A. So not on the surface P wave. So you measure from the local A to the His. And then our HV interval here, you can see you measure from the His to the initial deflection on the 12-lead EKG. So our HV interval here, as you guys can see, is minus 24 millisecond, which is not surprising since we are pre-excited, meaning the delta wave started. So you have a minus HV interval. Your normal HV interval is 35 to 55 millisecond. Any comments here?
One quick comment. I think that setup is beautiful. Actually, it works very well. Another way to do this, sometimes what I'll do, in particular if I'm thinking it's a left-sided bypass tract, is put a duodeca from the neck with the distal 10 poles in the CS, and that gives me another space to put in an ICE catheter so that I have groin space for ICE. So that's just another way to do things.
Nice. And this is
If you don't mind, I have a question to Dr. Amin. Do you typically use ICE in those cases?
If I'm doing a left-sided pathway, yes, right, because I do transeptal under ICE guidance.
Yeah.
It's
No,
really-
I meant more for ablation purposes, like contact and to know where you are and all of that.
I think it depends on where. If there's any question at all, I think ICE is very useful. It's always been a useful tool. Most of the time, I would say because most pathways are left-sided, yes, I would say we use ICE quite a bit for pathways. Occasionally, I'll go retrograde for a pathway if I can't get it transeptal if there's difficulty, but most of the time, yes, I'll use ICE. Right-sided pathway, sometimes I'll use ICE just because contact is difficult and I want to see. So, yes, ICE is useful. But, there are cases where you don't.
and we did use ICE in this case. We did use ICE in this case. Again, this is our surface 12-lead EKG, which also corresponds with our 12-lead EKG. Lead 1 AVL are positive when you have an RSR pattern, and AVF is negative. So it kind of corresponds to what we had on the surface EKG. So we started by RV pacing. And basically, we start RV pacing at 600 millisecond. And just again, this is for first-year EP fellows. When you try to RV pace, you look for a few things. You want to make sure you have a retrograde conduction first. So you want to assess the relationship between the V and the A. I want to make sure you have a one-to-one VA relationship here. The second thing you look into is you try to, as you are coming down, you want to assess, are you decrementing or not? And how much are you decrementing? So you're going to keep an eye on the VA timing as you come down on the drives, on the cycling. The third thing you need to look into is always what's your earliest retrograde A. And that's very important because it helps you narrow down your differential. So if your earliest retrograde A is His, you know that you are retrogradely conducting probably over the fast pathway or antireceptor accessory pathway. If your earliest retrograde A is basically proximal CS, then you start thinking, is this a slow pathway or posteroceptal accessory pathway? So all this information are very helpful. I really find starting with V pacing to be very helpful in my workflow. So here we have a one-to-one AV relationship, VA relationship, and our VA timing is 131 millisecond. We are coming down. We went down all the way down to 360 millisecond. And as you guys can see that our VA time did not change much. It's still around 130, 131, 135 milliseconds. So I did not see an evidence of decrementing so far. That's number one. Number two, this slide, when we are RV pacing, it looks like from a quick glance that we actually have a concentric activation pattern. But when you look carefully and you try to nail this down, we start to see a little bit of an eccentricity here. And I think the earliest retrograde A here is on CS5-6. And I'm going to zoom this slide in to again try to show you that. So we are not decrementing, and zooming. I think the earliest is C5, C6. Agree, Dr. Ahmed?
Yeah, I was looking at it and I was trying to figure that out. I was thinking either 7/8 or 5/6. They're very close, but you may be a hair closer with 5/6.
Sure.
And what you want to know now is where is 5/6, right? Because
Right.
if the CS is pulled back, it doesn't help you. But if the CS is where it's supposed to be, that tells you it's left-sided, which is
It's
what we
left
thought
side.
with
Right.
the 12 lead.
Right. And that's why it's important to always keep a like reference a fluoroscopy shot and make sure your CS is in a proper position. So from this slide, we can tell that basically we have retrograde conduction, eccentric likely, and earliest at CS5-6, and we are not decrementing. So all of this supports that we are probably conducting retrogradely over the pathway, or could be like a fused retrograde conduction. I think, what do you guys think of this sharp signal here? I was trying to tease out where is the hiss, honestly, and kind of was not sure where is the hiss here. Is this a far field A, or do we think this is probably a hiss and coming simultaneously on time with the A? It looks more sharpish than a typical far field signal.
Yeah, it's a tough one. I would have to see what the A looks like in sinus to, if the A is small, then it might be an A. His retrograde, you can see them often, but they're harder to see than an A. So I would look at what the A looks like in sinus.
Sure. So just quick summary again for you always want to start with RV. When you do RV pacing, you want to look for do you have a retrograde conduction? Is it eccentric? Is it concentric? If it's a concentric, you want to assess is it decremental or non-decremental. If it's decremental, this is likely an AV nodal conduction, but you have to always remember that some pathways can decrement. I think 10% of pathways are decremental, particularly septal pathways. So you have to take that carefully. If you're not decrementing, this is likely a septal accessory, like a pathway conduction. If it's eccentric activation, you always have to keep in mind that it's not only a left-sided accessory pathway, but also you could also be dealing with leftward inferior extension. I know some EPs don't believe in it, but it's part of your differential is having a leftward inferior extension of the AV node. Any comment on that?
No, I think it can happen. It's just not common, but it can happen.
Yeah. Okay, so next slide, we kept coming down and we basically continued coming down until we blocked. So so this RV pacing conducted to this A, this RV pacing conducted to this A, and this RV pacing conducted to this A, and we're pacing here and we blocked. So this is our VA block cycle length at 280 milliseconds. So we blocked at 280 milliseconds here.
Yeah, it's interesting. The VA after that is a little tighter than it is before. So,
Right.
but I think it's helpful to see block. It's hard to know, are you getting any progressive prolongation? It doesn't look like it's decremental. It looks like it's non-decremental, but the beat afterwards, it's a little bit tighter. It's just I'd have to magnify it to see whether that's just
We are talking about this VA time here, right?
correct. Yeah, that VA time.
This is a shorter VA time.
Yeah, and whether that's maybe going up the node or something. Maybe 7/8 is a little earlier than 5/6. I can't tell very easily. Maybe it's the same. I don't know. But either way, I think you have at this stage pretty consistently what looks like retrograde conduction up a bypass tract, probably in the left posterior space.
Great. Abdullah, do we have any comments in the comments box?
No, we're caught up.
Okay. So, okay, since I mentioned your name, Abdullah, what happened here? So we are RV pacing, we're at 280 milliseconds, and we're basically blocking here. So we have some of
We're
these beats
winky
are
backing
conducting.
there.
We're winky backing, we're blocking, and then this is the last paced beat. And what happens here? How
So
do you explain
this
this
next A
eccentricity?
is eccentric. It starts earliest at CS34. It's a true A. It's associated with an inverted P wave on surface EKG. Uh, it would be really unusual for this to be a conducted beat from the last ventricular pace because it would mean either a new pathway with decremental properties, which is something we haven't seen before, and more likely just an intra-atrial reentry or just an atrial echo, or basically, in simple terms, a PAC that came either from, uh, after pacing, from mechanical bump of something, or just having this excited status now of pacing.
Sometimes the CS catheter is banging a little bit, and the CS can be banging in the distal, and you get something like this.
It's a pretty dense signal on CS catheter too.
Yeah.
I thought it's a PAC or something like that. You can see that P-wave morphology is different than your sinus beat as well. So this is your next sinus beat that's not pre-excited. We're conducting, there is no delta wave here. We're conducting down the AV node, but the P-wave morphology, this is like you have an inverted P-wave. So this tells you this is not your sinus beat. And you can see this eccentricity. I think this is, I agree with you, Abdullah.
But what's strange here is we've been seeing a lot of pre-excitation before, and now we have like almost 2 seconds or 2.5 seconds without any pre-excitation. How would you explain that?
Yeah, what do you think?
I'm told this is concealment in the pathway from a lot of pacing. But we were winky backing for a whole second. Is that not enough to restore conduction through the pathway?
Sometimes pathways just take a little longer to come back. You know, as we see this. It's not uncommon. I think mechanistically, it's probably some type of fatigue in the pathway of some sort.
Here we started delivering some extra stems. So we started at 600, 400. So we're pacing from the RV at 600 drivetrain and an extra stem of 400. And we are trying to kind of define the ERP of the pathway or your retrograde conduction. And here we are conducting. So this is the last pacing spike here. We're conducting all the way up to the A. And I think we are going up the pathway here. And this is my interpretation. We're going up the pathway, then we're coming down the node, and then we are up the pathway, and then we blocked.
I agree. Beautiful. This is a beautiful example. You're entering, this is the start of SVT. Essentially, this is somebody who you give them a little bit of isoprel and you can sustain this. So this kind of finding is very important. You see something like this that tells you, oh, maybe I can induce SVT if I get the timing right with the extra beat or a little bit of isoprel.
Yeah. So this is an SVT trying to become an SVT. Just we have 2 beats of the SVT here.
Yeah.
And then we can see that we terminated on A, we blocked above the AV node here.
Yeah.
To be the devil's advocate, could this be a retrograde 2-for-1, like double fire?
I don't think so. I think, yeah, it's a good question. So what you're proposing is a double fire would be pacing in the RV. One would go up the pathway and the other would go up the node, but just slower, so going up the slow pathway. So
The CS activation, though, is identical in both, and it's
correct.
eccentric.
Yeah, I think because the CS activation is identical, it'd be hard to make it a double fire.
And the hiss. You got a nice
Makes sense.
hiss. That's a great hiss.
And you do have a hiss, yeah. Yeah.
Same phenomena here. We have the same observation again. So we're coming down now to 600, 260, and I think we still conducting up the pathway here. So we have not blocked yet. And then this is 600 to 50, and we essentially blocked in both the pathway and the AV node. So this is an ERP of both. I think we blocked in both the pathway and the AV node here. So the fact that we blocked at 600 to 50, what does that tell you from risk stratification standpoint, Abdullah?
Yeah, so anything more than 250 should be low risk for sudden cardiac death and VFib. Obviously, this is in this particular physiologic state in the lab, and you're also at a relatively longer drivetrain. 600 is okay, but um, I think it's still hinting us to this is another hint that this is a low risk pathway on top of the longer Winkelbach cycle length that we had previously.
But this is retrograde, though, right?
Retrograde, though. So the fact that it's retrograde doesn't tell you anything about the malignancy of the pathway, right?
Anterograde
Because,
ERP.
yeah, antegrade would be helpful, but retrograde doesn't help you. It may tell you about the ability of the pathway to sustain SVT, but not the malignancy of the pathway. But I think this pathway can sustain SVT based on the short reentry you had.
Yes.
So maybe you did some atrial pacing.
Yep. So, and here we have a VERP. So here we don't have a capture of the ventricle itself. So RVERP. So here we don't even have an RV capture, 600 to 30. Okay, then we moved on to RA pacing, and we start with pacing at 500. And as you can see here, actually we blocked pretty early. So at 500, we're already blocked. You can see the first two beats are pre-excited, and then we have loss of pre-excitation with third beat. So we have an excessive AP block cycle length was at 500 milliseconds. So again, like this just based on this tells me it's probably a low risk pathway, but we don't know how this pathway behaves once you are under a high adrenergic status. So stay tuned, I guess.
I guess the only other question is the patient asleep, not asleep? Are you under general? How are you sedating the patient?
And here we are trying to define the ERP of the pathway and the node anterograde. 600, 400, we're still conducting, we're pacing from the atrium here. We're conducting all the way down to the A, and we know we're conducting over the pathway because we still have a delta wave here. We're pre-excited. So this is an anterograde conduction partially through the accessory pathway. And we keep coming down, and we are still pre-excited at 600, 340. And we're still conducting down to the V. We continued coming down, and at 600, 330, we actually blocked. And we blocked in both the AV node and the pathway. So this is the AP-ERP, I called it, and which is also the AV nodal ERP. Agree?
Yes.
So we are pacing from the A, and we blocked in the AV node and in the accessory pathway.
Again, I think the question is: is the patient asleep? Are they under general anesthetic? What's your sedation?
Moderate sedation. So sleep, yeah. Patient sleep. Yeah.
So we have a comment that somebody in the audience wants isopril.
Sure. Can we do one more maneuver before we put the patient on isopril? Okay. I hear Lama. Is Lama on the line?
Yeah, I'm here.
Okay. Lama Jibawi used to be my co-resident, and she just finished EP fellowship at Henry Ford. Lama, if it's not too much, can I ask you to look into this maneuver?
Yeah, sure. So I believe we're attempting parahissin pacing here. First, we have to comment whether this is a valid maneuver or not. And clearly, we're pacing from the His catheter, and we do not have a direct atrial capture because if you see from the pacing spike to CS910, we're not measuring exactly, but it's more than 60 milliseconds. So I think it is a valid parahistin maneuver. And if you look at the beats that Ahmed is measuring, so the first beat where the interval is 120 millisecond, if you look at the surface EKG, it's a narrowish QRS complex. So this is you have his capture here. And if you compare it to the next beat, where it's a very wide QRS complex on the surface EKG, then you would consider this loss of his capture. And we're going to have to compare the VA conduction basically between his and loss of his capture. And basically, we're trying to assess the transmission of the impulse from the V to the A to the atrial chambers. Is it conducting through the node or through the pathway, or what's going on? So there's no difference in the VA timing, right? It's 120 millisecond versus 119 millisecond. So this is what we call an extranodal response. Basically, the impulse is going from the V to the atrial chamber using an accessory pathway. Because if it was conducting through the node exclusively, then when you lose his capture, you're going to have to see prolongation of that VA timing. So I would call this an extranodal response.
That's a good.
Excellent. Excellent, Lama.
Quick question, Lama. You said it's a His pacing maneuver. What do you do? How do you do this? What's your approach?
I would usually start at high output and go down until I see the change in the QRS morphology and what I would call loss of his capture. But also we have to, because a lot of the time we're actually capturing A at the same time. So that's the first thing I look at to make sure I'm not capturing A at the same time.
Yeah, perfect.
Thanks, Lama. This is really great. So there is actually so many board exam questions where they give you a para-Hessian pacing maneuver, and the first thing they throw on you, like, is it like they want you to identify that you're capturing the A, and if you're capturing the A, the maneuver is not interpretable. As you mentioned, the people use different cutoffs, 60 milliseconds. So 60 milliseconds from the pacing spikes to the A. If it's less than 60 milliseconds, people call this an atrial capture. You don't want to have an atrial capture when you are doing this maneuver. So basically, just to go, I think the first beat is a pure His capture. If anybody would like to correct me on this, I think this isoelectric line here, we're only capturing the His, but I think the second beat, we have an RV and His capture, and this is on high output. And then the third beat is when we have an RV only capture. So we are transitioning from high output to low output, and we are seeing a loss of the His capture. And with that, we're seeing a fixed VA interval, which goes along with extranodal response, suggesting that you have a pathway, typically a septal pathway. The other trick that I saw people like for board exam purposes that they ask about is sometimes they give you what looks like a nodal response, meaning the VA timing did change, going from high output to low output, but you will see a significant change in the CS activation pattern. And it's a common board question that it shows up a lot on ACC SAP and stuff like that. And they want you to recognize you don't only look at the VA timing change, but also do you have any change in CS activation pattern? And they call it a pseudo nodal response. So that's another thing to pay attention to. I think that's it. I think it's a very helpful maneuver. I mean, you do this maneuver in science, obviously. And so the question I really had is how helpful this pathway when you have a left lateral accessory pathway as opposed to septal accessory pathway?
Yeah, I think the utility with the left-sided pathway is a little bit less. I think this is most helpful with anything septal.
Sure.
But it does.
Ahmed, لو تسمح لي, I think we went over the Parhesian pacing maneuver. I just want to survey the audience. Please write in the comments if you think you need more elaboration on Parhesian, because we have a few more slides. Otherwise, maybe we can save some time and go to the next CGM. What do you think?
I think so, because we're running out of time.
So if a lot of people need more elaboration on Parhesian pacing, we can go over it quickly right in the comments. Okay, I'm not getting anything.
Okay.
So I think we can keep going.
Yeah, I'm happy to share my slides. I'm happy also to figure out sometime we can go over some of these maneuvers.
Yeah.
This is just elaboration for the concept of nodal response and extranodal response. So I'm going to skip that. This is not our case. This is for elaboration. Okay, so TAC initiation. So someone wanted some isopril. So we put the patient on some isopril. Is Lama still there? I'm gonna pick up on you again.
Yeah, it's okay. I'm here. All right. So this is
Okay.
initiation finally. All right. So the first two beats are sinus beats with pre-excitation. And we can see that from the surface EKG, you have a delta wave and you have a very short HV interval. And then the third beat looks like a PAC that's going down what I
This one.
say. Correct. Going down the node with what I would say just normal decremental properties of the AV node. You have lots of pre-excitation, and then you have a retrograde conduction. And this is what it looks like as VT initiation. All right, so looking at the retrograde conduction, first of all, looking at that CS activation, it's kind of the same CS activation that we saw when you were doing straight VA pacing with that eccentricity. And again, as Dr. Al-Ahmad pointed out, it's not very concentric with what we have initially thought a receptor pathway on the surface EKG. If you drop a caliper, yeah, maybe 5-6 is earliest. Not quite sure, but it's not concentric as we expect it to be initially on. And then if you look at the hisses A, you can see that the CSA are earlier than all the hiss A's. So this is also like point that it's probably going out that the retrograde limb is using an accessory pathway rather than a node. Because so far we haven't seen any proof that the pathway is actually participating in the tachycardia. And this is first hint that probably the retrograde limb is actually using this accessory pathway that we now think is probably somewhere in the mid CS as opposed to the posterior septal. And then I think you guys attempt later maybe some overdraft pacing. The first one captured, the
Yep.
second one doesn't.
Well,
Yep.
there's also PVC you put in, but I don't see it.
I think this is just a PVC came in, but I will show you more slides. But I agree with you, Lemma. This is a PAC that kind of initiated the tachycardia, and I think what as you elaborated, this PAC basically conducted all the way down to the his, the AV node, and came up the pathway, then down the his, and up the pathway, down the his, and up the pathway. Are we in agreement on that? So this is essentially continuation of the initiation. So we are in tachycardia now. Tachycardia cycle length is 370 millisecond. A few things you always want to look into. Number one, you always want to tease out what's your septal VA time, because the septal VA time less than 70 millisecond basically rules out a typical AV-NRT as a mechanism of tachycardia. It's very helpful to measure the VA time here. So your VA time is 78 milliseconds. The second thing I always look into is a wobble. We don't see a wobble, but it's really very helpful if you have a wobble to see what drives what. Is it like the A to A driving the H to H, or change in the H to H driving the A to A? It kind of helps you narrow down your differential. So these are a few things I will look into here. And then as Lama suggested that she wanted to do a ventricular overdrive pacing. Ventricular overdrive pacing is when you basically pace from the RV at maybe 20 milliseconds faster than the cycle length, and you try to entrain the A and advance the A and see what kind of response you have. So here we tried to perform a ventricular overdrive pacing, and what happened?
This is for me too. Okay. So we're overdrive. First, we're overdraft pacing. We have to make sure that we're actually in training, and you're doing that. You're showing us that you actually entrained the tachycardia, advanced it to 340 milliseconds and so. And then you come off pacing, we're going to have to assess the response here. So what are we seeing? So the last pacing spikes, you see a V, obviously, and then you see an A, and then a H, V.
I'm tricking you, Lama, here. What happened to the tachycardia?
Terminated.
It terminated.
Oh yeah, it terminated. Sorry, I have the faces on, so I don't see the rest of the screen. Let me
Oh,
minimize
okay,
the
sorry.
faces. Okay, yeah. Yeah, so yeah, tachycardia terminated. So next
Yeah.
slide.
So exactly. So tachycardia terminated. I think this is a junctional beat here coming in, if I'm not mistaken. And then the next beat, this is a pre-excited beat that comes back. But this is you were very systematic, Lama. I really appreciate it. So basically, we tried to RV drive pacing, and we tachycardia broke. Then it reinitiated here. Again, reinitiation followed the same exact mechanism. You have a PAC initiated the tachycardia. and now we are back in it. And again, we are trying to do a ventricular overdrive pacing. And the trick here basically is before you jump on interpretation of this, we are not capturing the V here. So you're pacing, you can't assist the response because we're not capturing the V. So this is not a proper maneuver to do, despite all these measurements and tricks. So don't let your attending fool you on this. So this is not interpretable. And then this is gonna go back to Lemma again since you started this ventricular overdrive pacing. So what do we see here, Lemma?
Okay, so again, we're in training successfully, and then we come off pacing and the tachycardia continues. Back to what I was saying earlier. So you look at the last in-train beat and you want to see what is the response after the tachycardia resumes. So you have it where Ahmad has the 136 milliseconds. So this is the last pace beat.
Lemma, how do you know you're entrained?
I'm trusting you.
Say it again.
I'm trusting you because this is the third slide of overdraft pacing that you're showing us.
I am giving you measurements, 300 milliseconds. We are
Yeah.
pacing at 300 milliseconds.
And
Never
then
trust anybody in the EP lab. Trust no
What
one.
was it?
He has measurements.
Yeah. So I'm giving you measurements. So you're measuring the A to A on the CS catheter, and it's 300 milliseconds. So we accelerated the A to the pacing cycle length. So we are in train. Sorry, I'm going back to some very, very basic stuff because I know some of the audience, we have some first year EP fellows and we're still in July. So
No, that's very valid. Yeah. So obviously we have to confirm entrainment every time we do so. And as Ahmed mentioning, you're pacing at 300 millisecond and you're advancing the tachycardia or speeding up the tachycardia to 300 millisecond as measured by the AA intervals. And then we do come off pacing. And the response is a VAHV. So this is a VHV response. And a VHV.
What's your differential for VHV response?
Correct. So basically, we're ruling out an AT. This is an AVNRT or AVRT. And then we're going to have to look at the PPI minus TCL. So the PPI here is 392 and the TCL is 315. So this is more pointing of, AVRT as opposed to AVNRT or atypical AVNRT. And I know from the start of the case, we have hinted for a pathway and so whatnot for so many times, but till now, we have not confirmed that this is an ORT. So these are the actual diagnostic maneuver that we still have to go through over every single case before jumping and burning. So again, VHV response and a PPI minus TCL confirming, and you can also do the STIM A to VA, which is 136 millisecond, and VA is 76 millisecond, which is also confirming that this is an AVRT as opposed to AVNRT.
Excellent, excellent. Just want to just go slowly over this. So we advance the A and we look at the last in-train beat. It's very important to define what's your last in-train beat because otherwise you might be fooled. So this is your last in-train beat. How do we know? Because this return beat is longer. So this is the last in-train beat. And then you want to see what happens. So you have a VAHV response as opposed to VAAV response. A VAHV response rules out atrial tachycardia. So your differential is narrowed down to AVNRT versus AVRT. The next step is to look at your PPI, the post-pacing interval, which is what I'm measuring here on the RV electrogram here. So this is your post-pacing interval. You subtract this post-pacing interval from tachycardia cycle length, which is 315 here. And the cutoff values are 115 milliseconds. So anything above 115 milliseconds goes along with AVNRT. Anything below 115 milliseconds goes with AVRT. Again, if you want to be a little bit more an EGM nerds, a lot of the literature also talks about corrected PPI minus TCL, and some people ask about it. So corrected PPI minus TCL is sometimes you have to correct for AH prolongation. So I can send you some references on this, but basically you measure the AH during tachycardia and AH during RV pacing, and you subtract the difference, and you subtract that AH difference from the PPI minus TCL. This will give you something called corrected PPI minus TCL. And we have been fooled in the past where we have a PPI TCL that's more than 115, goes along with AVNRT, but when you correct for the AH prolongation, your PPI minus TCL actually becomes less than 110, which is the cutoff, which corresponds with AVRT. So it's nice to consider these things. The other surrogate that Lemma measured is what we call as a stim to A. So you measure from the last pacing time, the stim, the RB stimming here, to the A, which is 136 millisecond, and you subtract that from the V during tachycardia. This is your V to the A. So your VA timing in tachycardia minus VA timing during RV pacing. And the cutoff they use for this is 85 milliseconds. So anything below 85 millisecond corresponds with AVRT, while anything above 85 millisecond corresponds with AVNRT. So these are like, this is, I think, one of the very important maneuvers to master and know it very, 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 very well. The other very common board exam question is they will give you what looks like a VAAV response, but because you did not define the last entrained beat, they fool you with something called a pseudo VAA response. I can send you an article on that as well, but this is also something you will hear about it in the EP lab, pseudo VAAV response. Just keep it in the back of your mind. I don't want to talk into details about this. I think this is a good review for this maneuver, VAHV response.
One quick question, and it may take a couple of minutes, but can one of our experts comment on the sequence of activation? So during VOD, we see that the His signal precedes the HRA signal, and then when you go back to tachycardia, HRA precedes the His pretty well. So why did this change happen?
Sorry, atrial tachycardia? Did you say atrial tachycardia? You ruled out atrial tachycardia with this maneuver. It's effectively ruled out. The big question with this is it AVRT or is it atypical AV node reentry? Because typical AV node reentry wouldn't look like this. So, and then by using these maneuvers, you can tell the difference pretty easily. But at this point, you've built a case. You've got manifest pre-excitation. You have clear delta wave. You have retrograde that's eccentric, that's non-decremental. You have tachycardia that appears to be using that by more than one mechanism. I think at this point,
time to ablate.
pull out the ablation catheter. Yeah.
Okay. Sure. We went over this.
Abdallah, to answer your question, could it be that our higher atrium catheter changed position during actual tachycardia, which we do see commonly?
Possibly, yeah. Possibly. And also, I was kind of trying to pay attention to how the His activates on the His electrogram. Like, is it activating orthodromically or like, I can see like here, for example, I was trying to kind of tease out, I think this is the His and this is the His on T3. So I think this is a high to low His activation. So I think this His is also activating orthodromically. So we're going up the pathway and then we activating the His orthodromically. Is this accurate or am I making this up?
No, I think that's reasonable.
Oh, okay. Dr. Hamoud is saying no, so it's no.
No, he says no. He's my teacher, so whatever he says is correct.
Absolutely. Absolutely. Okay, so I'm making things up here.
No, you're not making things up. I don't think you have enough information. That's all I'm saying is that this is difficult because to tease things out, you really have to be able to dissociate the His from the A to determine if this is part of the A or part of the His. You seem to be going up the A very nicely, and then you're going down. You can see a nice His antigradally going down. So it's hard to say if that's a retrograde His or not. I don't know. My answer is I don't know.
The thing is, your His A is in the middle of that a little bit too.
Yes.
So it's hard to know what's His and what's A. So
it's hard to tease it out, yeah. Okay. We talked about this, the thresholds and the cutoffs to define PPI TCL and the threshold for STIM to A minus V to A. Last maneuver, I promised, just going to go quickly. This is his PVC maneuver. Basically, what happened here, we delivered the PVC when we are hissing, and you have to confirm always that you're hissing. And the response here, tachycardia terminated. And the way you interpret this maneuver, if you have a termination of tachycardia with hissing PVC, this does not only tell you that you have a pathway, but also it tells you that it's also participatory in the tachycardia. So that's a maneuver we also did during this case. We talked about this. I continue these slides. This is explanation of His refractory PVC. So going to the money now. So case summary, we have a pre-excitation at baseline, a young guy with symptoms. Retrogradely, we have eccentric activation, non-decremental conduction. We have an extranodal response. We have hissing PVC with termination of tachycardia. We have VAHV response, and we have a PPI minus TCL less than 115 millisecond. And we have an APARP more than 250 millisecond. Next step is to pull out the ablation catheter and to start mapping and to figure this out. I'm just going to skip on this. Actually, I'm going to just mention this. This is a different case we did, but the only reason I'm showing this is why we do an EP study and why we ablate is because patients can go. This is an example where like the patient degenerated into atrial tachycardia that conducted through the pathway and patient had basically ventricular fibrillation. We have to shock him out of it. So that's why we ablate these pathways, not only because of the symptoms, it's also for the risk of sudden cardiac death, especially in high-risk pathways. Going back to the ablation time. So we did transeptal puncture. I disappointed Dr. Al-Ahmad. We did not map on the right side. We went directly to the left side. I don't know if that was the wrong approach or not, but
that's the right approach. I would just say always be ready to map and keep an open mind. If you
absolutely
can't do something on the left, then map on the right. But yeah, you're correct to map on the left. There's no question.
Sure. So established ice-guided transeptal puncture. We had an ACT more than 300, and we crossed, and we have our ablation catheter on the left side. Question to the audience or to you, Dr. Al-Ahmad, what would be your mapping strategy here? Like, how would you think about, are you going to map the earliest V? Are you going to map the ventricular insertion? Are you going to map the atrial insertion? Are you going to map both? Does that have any value to the mapping process?
Yeah, I think for each case is a little different. It depends on what your most stable thing is. So for example, if you're pacing retrograde and it's sometimes get node, sometimes get pathway, or it's a merger of the two, then I try to not map retrograde. If you can map with SVT, that's really, in my view, the best. But if you can't get consistent SVT or it degenerates to AFib or other issues, then you use whatever you can use to map these. So sometimes that's antegrade, sometimes that's retrograde. If I have the luxury, I map both actually. So I've started using this open window mapping.
Yeah.
So I'll map antegrade and I'll map retrograde and put them both on the 3D map.
I'm going to show you an image here to reference to the audience.
I'm going to blade after that. So that's what I will do nowadays.
That's the open window mapping that.
Yeah.
Do you use open window mapping at all?
I do. I really like open window mapping. I think it's a clever technique.
Yeah. Basically, you need to map the A and the V at the same time, and you delineate the lines of discontinuity or lines of block. In this case, we're showing it here. This is a different case, but I'm just showing it for reference for open window mapping. A lot of people use it only for redo cases. I don't know if there's an added value to use it in every case.
I actually like to do both A and V open window mapping together if I can. That way I have both on the map and I can see where the pathway is exactly.
I have to say it's visually very appealing.
Oh.
And in this case, for example, we actually did both. We annotated manually and then we confirmed with open window mapping, and the open window mapping method was kind of correlated with the point by point. So it's a neat way. I like it, honestly. So I'm going to just go back to the mapping here. So the ablation catheter, proximal and distal are on the red side here. And as you guys know, when we are mapping, we are looking for the site of insertion for this accessory pathway. So here we are in pre-excited rhythm. So since you are pre-excited, you want to map the earliest V. So you want to look for the earliest V on the ablation catheter, and you want to see an AV fusion. And that's basically one of the clues that tells you that you are at the insertion site. In this case, actually, we did not get a very early V signal, but what we got is a very sharp deflection here that we thought is a pathway potential. So we went after the pathway potential. We have a nice QS on the unipolar ablation catheter. I don't think we're very early relative to the surface EKG, but we have a very nice pathway potential here. And actually, we want after that. And just here trying to show the timing. Again, I don't think we are very early here. So we came on at this particular location. Any comment on this?
Yeah, I mean, I look, I love finding that beautiful rooster head continuous signal. I love but what I'll do is I'll do the open window mapping, get my catheter close, and then if I find something like that, I might take it. There's been a few pathways that are, for example, redo, where it's not always a beautiful signal, and you just have to occasionally learn by burning. So I don't think it's wrong to burn in a situation like this. It looks like a decent area. I wonder, what do you think? Would you ablate there?
I would. It looks incredible. And
Yeah.
I fully agree with you. It's, and this would make Sonny Jackman so happy. You're
Yeah.
not going after the earliest A, you're going after the potential. And this is an amazing potential.
So did you get it? Let's see
Let's see. So 1 beat, 2 beat, 3 beats, 4 beats. The 5th beat, we lost pre-excitation.
Beautiful.
So we lost pre-excitation, I think after 5 seconds, 4 seconds, I believe. And we have never seen any pre-excited delta from one single lesion at this exact location. So Dr. Hamoud, you could have put your money on this. It was very beautiful, like one
Beautiful.
lesion, yeah, single lesion, 4 seconds, delta wave was abolished, and there is no evidence of accessory pathway on surface EKG.
Let me ask you two questions, Ahmad, since you did this case. It's a beautiful case. Question one, what power setting did you use? What contact force did you have? And then question two, did you do anything at the end to see if the pathway would come back?
Yeah, I think we used a 30 watts at this location. I don't know if that's conservative or not. I know people can go higher, but we used, I think we went between 30 and 40, but nothing higher than that. And we stayed for 1 minute on each lesion. We delivered one lesion here, and then we consolidated with 2 or 3 other lesions around this area. And that was it. So 3 or 4 lesions.
This was the catheter, Tactiflex?
Tactiflex, yes.
Yeah, 30 watts with Tactiflex is probably adequate.
Perfect. Would you go higher than that?
Tactiflex is a little different. The current density is a little bit more than with, say, STSF. That one has a little bit, I'd probably use 40 with STSF, 30 with Tactiflex. So I think you're on the money.
Sure. And I want to also show you that we ended up ablating almost at 5, 6 o'clock on the mitral annulus. So we are kind of where we expected almost. So we are not far off. So to answer the second part of your question, these are the maps we have. The second part of this, I want to actually really emphasize this a lot. So the second part, after we ablated, we spent some time testing, did we get the pathway or not? So to do that, we did a bunch of things. Number one, we don't have any pre-excitation on surface EKG, which is good. Number two, we started with a parahesian pacing that's showing us an extranodal response. So after ablation, we repeated the parahesian pacing maneuver, and we saw that we now have a nodal response. So that supports that we possibly could have at least a retrograde limb of this pathway. Number three, we were V-pacing and looking for eccentricity because it was very eccentric. And number four, we looked for SVT inducibility, and we would not be able to induce SVT. However, we also used adenosine, and we used adenosine to check for anterior grade block and retrograde block, and we also used differential RV pacing. Surprisingly, and this is where I really appreciate your thoughts, we pulled out, we are back in the right atrium, we lost our transeptal, we're RV pacing, and we have this eccentric activation pattern back on our, and we were very disappointed at this point. So we were like, our gut feeling, okay, now we have this eccentric activation, what could this be? Possibly residual pathway, so we started testing again. And I'm gonna show you what we did. So this is our parahesian pacing maneuver. And you can see now we have a nodal response your VA timing changes significantly between when you have an RV HIS versus no HIS capture. So this is a nodal response, which goes against the pathway. Initially, when we started the case, we have an extranodal response. And then we did differential RV pacing. And I don't know how often you guys do differential RV pacing, but we pace from the apex and we pace from the base. The idea, if you are pacing from and we measure the VA time. The idea, if you have a pathway and you are pacing from the base, your VA time should be shorter than the apex. If you don't have a pathway, your VA time should be longer otherwise, because you have to travel all the way from the base down to the apex and then engage into the Hess-Purkinje system. So with differential RV pacing, this is pacing from the apex, 247, and then when we pace from the base, our VA time actually was longer, which supports that we don't have a pathway. I understand this is more relevant to septal pathways, but this is one way to test for it. And then what we did is we gave adenosine, and we gave adenosine 6 milligrams adenosine with RV pacing. And you can see here on the fourth beat, on the third beat, so this is conducting up to the A, conducting, and then on the third beat, we blocked. So with RV pacing on adenosine, we have no evidence of retrograde conduction over the pathway. And then what we did is we repeated the same thing with RA pacing, and there is no also anterograde. There was a block anterogradely as well with adenosine. So honestly, at this point, we just try to, how can we explain these findings? The only thing we don't have any, we are non-inducible. There's no delta wave. You're not pre-excited. You don't have any evidence of pathway in all these EP maneuvers we did. The only thing we have is intermittent eccentricity with RV pacing. And our thought process, honestly, we invoke that this could be like a leftward inferior extension of the AV node. I'm not sure if especially Dr. Hamoud and Dr. Ahmed agree with me on this interpretation, but that's what we ultimately concluded, honestly. And then what we did not do any more ablations, and we actually did mapping and RV pacing in sinus to delineate the earliest A, and that was at the slow pathway location.
Yeah, I would get out of there. I think you're done. I think sometimes you don't have to explain every phenomena as long as you have a good outcome for the patient. I think this was a master class in ablating WPW, SVT, beautiful electrograms, beautiful explanations, outstanding job.
And this is the post-ablation EKG, and we basically have no more delta waves.
Ahmed, what I was trying to say, I didn't think I said it well, was that you don't have to explain every phenomena. You do have to care for the patient. And sometimes the enemy of good is bad, in the sense that you can be chasing your tail. And I've seen people do this, in particular early career. I've seen people chasing PVCs that are non-clinical and doing things like that because they feel like they have to do everything while they're in there. And the answer is you don't. You did a great job. You've proven to yourself that pathway is gone. That pathway was the problem. You can see how the patient will do clinically, and that should be good, rather than take extra time with the patient on the table. So I think all in all, outstanding job.
Thank you so much. You reminded me of one of the VT speakers always say that the biggest prognostic factor in predicting mortality in VT ablation is the duration of the procedure. The longer, the worse. So sometimes you have to stop chasing yourself and kind of be happy and be kind of cherish what we have. We did use isoprel again at the end.
Yeah.
Abdullah, do we have any questions? Any questions from the audience? Dr. Mundir Ahmoud, thank you for really joining us, and didn't expect, and Dr. Mirbat as well, Abu Maati.
Yes, I would like to say a comment.
Absolutely.
Yeah, back home in Egypt, I mean, if I have an athlete like this man who has asymptomatic WPW, he is not allowed to practice sports, any kind of sport, competitive, non-competitive, unless he is ablated. This is a rule nowadays, was put by the government, and a committee for sport participant. And each person who practices sport has to be checked with ECG and echo. This is why, because we got some mortalities in the field, in karate, in other sports, in swimming. So in order to predict the players, we do this. Since then, we have many players or athletes, practicer, who have WPW, and I myself, I go and ablate them, even if they are antroceptal. In case of antroceptal, we use the freezer, the cryo freezer, in order to avoid heart block. Otherwise, the child or the teenager or the sportsman will never be allowed to practice sport in the club. From the ECG, I was suspecting a diverticulum because there was a negative delta in 2, 3, and AVF. It is not isoelectric. I see it negative. And when we start, we pace from atrial pacing to see manifest pre-excitation near the CS ostium. And I would go mapping right side first and go inside the CS and look for any pouch. I don't inject unless I am sure there is a diverticulum, which I go inside with the caster. Then we do transeptal and go to the other side. We do some maneuvers, but if you have a pre-excitation and then you get AVRT, it is a must that you ablate the patient, because he is asymptomatic, but many of them get the tachycardia while they are practicing sports and they don't understand that this is tachycardia. The problem is that he gets pre-excited AFib, as the one you showed, and he collapses in the field. In Egypt, we don't have the automatic defibrillator, AID, I mean the automatic defibrillator in the field. So if he gets VF, he will die. And we have many examples of this who were resuscitated by CPR, but at the end it ended by cerebral hypoperfusion and mental retardation. So when we see pre-excitation in a sport practice, a man or a woman or child, we go after ablation. This is what we do back home. Open window mapping, we started doing it when Dr. Mohammed Said from National Heart Institute in Egypt joined my team. And we don't do it for each case. We do it for the difficult cases or for the redo cases, because this is cost. We use conventional ablation all the time for all accessory pathways, except some antroceptal. I would go 3D, the parahesian, the true antroceptal. I go 3D and freezer. And this is especially in children, because we don't want to do any harm. I think that was a very nice session, interactive and basic electrophysiology. I think that all fellows need to understand the signals, and the explanation was excellent, Dr. Ahmed Amin, and all the participants, especially Lily. I think her name was Lily. That's
I think
Lama.
Lama.
good to hear perspective from other countries and other groups that do things differently. I think with this, I'd like to adjourn the session. Outstanding job, Ahmad. Thank you guys for organizing this, and see everybody in a month for the next EGM session.
Thanks, everybody.
Bye.
Thanks. Thank you so much. Thanks, everybody.
شكرا جميعا
Abdullah,
شرفتونا.
of course. So next
See you
week
guys
it will
next month.
be, do you know who's presenting next week, Abdullah?
Thank you, everyone.
Next month we have Ahmaras and Dr. Fatima Azzuddin from Mayo Clinic.
We have a nice case from Mayo. I think Waddah will be presenting, and the moderator will be Dr. Fatima Azzuddin. Inshallah, it will be a great case as well. Thanks, everybody.
Please send feedback, reach out in any way you see appropriate, and send feedback. Looking forward to see you soon.
And also, if anybody wants the slides, I'm happy to share.
Sure. Let's use Google Translate to check what's marshmallows.
Okay, we have no more questions. We are going to end this meeting. Thank you.